This program is brought to you by Emory University.
So Mike and I went to medical school together. He was in my class. And it's been really fun to see how he has really become an international national expert in anticoagulation, antiplatelet therapies. He directs the STEMI, the cardiac cath lab at Grady, and is also involved in the PERT team at Midtown and Grady, and also at Emory. So, Mike.
All right. Well, thank you very much. I appreciate it. Chris, are we good? Everything's going? All right, sounds good. Well, let's get going. I think that the reason I kind of wanted to give this talk was I think there is some interesting new data out, and it might be time for us to kind of look at our practices, kind of recircle back on some of our practices over the couple of years and see if we want to try to maybe get some consensus. And I want to try to get through this so we can have some discussion at the end. So we're going to go through 4 things. We're going to spend most of the time talking about DAPT duration. We're going to talk a little bit about the data on low-dose Rivaroxaban, how to combine antiplatelets and anticoagulation, and then talk a little bit some of the new Prasugrel and Ticagrelor data. And I think one of the themes that's going to come up is that it's been a bad year for aspirin. I think we know the story in primary prevention, and I do think we're going to start to see its role questioned in some of the secondary prevention areas that we've used it before as we go through this. So what is the optimal duration of dual antiplatelet therapy after PCI with drug-eluting stents? So this is really where we want to focus. And for the fellows out there that are listening, it's important to remember, why do we give dual antiplatelet therapy? And it's to prevent stent thrombosis. That's really what changes when you put a stent in. Before you put a stent in, they don't have stent thrombosis risk, and then after the stent goes in, there's a risk of stent thrombosis. And so when you look at DAPT, when you look at this risk of stent thrombosis, this is data from the ADAPT-ES. It shows where this risk is located, and you can see that it's not evenly distributed, but it's very prominent in the first 30 days. In fact, this is where the majority of stent thrombosis that's going to occur after drug-eluting stents is within this first 30 days. And then there may be still a little bit of clustering within 90 days. And then after 90 days, there is stent thrombosis events that still occur, but they're very lower incidence. The other thing to note is that not every stent that goes in has the same risk for stent thrombosis. When you look at 30-day stent thrombosis risks based on presentation, you can see that elective PCI stent thrombosis is almost non-existent, at least in the DAPT-ES registry, 0.2%, so 2 in 1,000. We should not be seeing many stent thrombosis events in elective population. But there still is stent thrombosis that's occurring early on in our STEMI patients, and at least up to 1.5%, and in some other registries 2 to even 3% in our ACS population. So important to remember the differences between stent thrombosis between our patients. So what do the guidelines say? Well, there are guidelines on the topic. This is the 2016 guidelines from the ACC and HA on DAPT duration. And for acute coronary syndromes, for STEMI and non-NSTE-ACS, it's a class 1 indication to give DAPT for 12 months, for at least 12 months for an acute coronary syndrome. So this is whether you present with medical just present and get medical therapy, bare metal stent, drug-eluting stent, bypass surgery, 12 months is the recommendation. Now this has been the recommendation for years and largely based on the CURE trial. Very well done trial, large trial. Over 12,000 patients with acute coronary syndromes randomized to either get single antiplatelet therapy versus dual. And you can see there was a benefit to dual antiplatelet therapy up to the year mark, and that really set the stage for a year of dual antiplatelet therapy. But a couple things about this trial. It was majority medically managed. There was not a majority PCI population, and this predated drug-eluting stents and certainly predated our contemporary drug-eluting stents that we're using. And it was over almost 20 years ago that it was published, and so the question is, does this still represent contemporary practice? And if you look and say, does the guideline, following the guidelines and giving everybody at least a year of DAPTs, improve mortality compared to shorter courses, the answer is pretty clear that no, it doesn't. There are now compiled randomized data, over 12,000 patients with acute coronary syndromes that are randomized today with contemporary drug-eluting stents to shorter courses or our contemporary year or more of DAPT, such as the guidelines. And when you look at mortality, all cause through these randomized trials, you see there's absolutely no benefit to giving every one of our patients a year of DAPT. And the reason for this is that there's competing risks, and we know this. There are benefits to dual antiplatelet therapy, that we do reduce myocardial infarction by giving patients dual antiplatelet therapy, and however, it's offset by the risk of bleeding complications in a lot of our patients. And so these competing risks are hard to escape, and it's going to be one of the themes of this talk today. Well, what about stable ischemic heart disease? What do our guidelines say? Well, it's a class 1 indication to give dual antiplatelet therapy for 6 months after drug-eluting stents. And it's interesting that the guidelines were moving more conservative in 2016, although I don't see this done very much in practice of 6 months of dual antiplatelet therapy. And in the guidelines, they showed this meta-analysis of randomized trials that were looking at shorter courses of 3 to 6 months of dual antiplatelet therapy compared to what was then sort of the contemporary of giving everybody a year of dual antiplatelet therapy. And you can see that when you look at hemorrhagic events, they were favoring shorter courses. And it was already noted that these patients with stable ischemic heart disease had less ischemic events, so there was not any higher worse thrombotic events by shortening these courses. So there was more bleeding without having worse ischemic events. And when you look at mortality, at least in the guidelines from these initial trials of randomizing to shorter courses, you can see mortality not statistically significant, but trending towards favoring shorter courses. And I'm going to show a couple of other things. I just want to show you where the trend heads in a lot of the mortality data trends towards favoring short over long. Well, what about extended therapy? Certainly, a lot of times when patients come back to see us in clinic, they're doing well, and the inclination is, if they're doing well, is you hit the refill and you refill DAPT. That's what's often done. The recommendation for hitting that refill button and refilling dual antiplatelet therapy, it's a weak indication. It's a 2B indication for patients who have tolerated DAPT to continue DAPT. So it is something to consider. It's not certainly a high recommendation. Now, the DAPT trial is probably the biggest trial that looked at this question. So it was a very large, I'm sure many people, we've talked about this in this room before, almost 10,000 patients. They were all-comer PCI, and they had to be doing well. So they were doing, if they did well for the first year of getting dual antiplatelet therapy, then they came back and they got randomized to either coming off the one of the antiplatelet agents and going single versus dual antiplatelet therapy, and then they got followed up after that. And what you can, and this is a real world question. This is the patient's coming back to your office. Do you refill both agents, or do you drop one and go to single antiplatelet therapy? And what they found in the DAPT trial was that there was a benefit with MACE to refill that DAPT, to continue patients on DAPT, compared to a single antiplatelet agent. But, you know, it's a modest benefit, number needed to treat of 63. But what was important about the DAPT trial is it was a very large trial, but it did take a long time to enroll. And so over half the trial used stents that we don't use anymore. These are out of date and not in clinical practice anymore. And so when you go back and you analyze the half of the trial, the DAPT trial, that used the contemporary stents, the everolimus-eluting stents that we're putting in today, and you go back and you look at this primary outcome, the MACE event, you can see there wasn't an overall benefit to the continuation of dual antiplatelet therapy after a year in this group of patients that get stents that we put in today. Now we can talk about some of the individual components that made up this composite, but in total the MACE benefit was not there for patients in the population. But what was there is more bleeding. So there was clearly more bleeding when we used extended dual antiplatelet therapy compared to dropping one of the agents and staying on single antiplatelet therapy. And so when you go back now and then look at a meta-analysis of almost 35,000 randomized patients, 12 randomized controlled trials, that then look at the shorter courses, patients who are, this is a lot of different data from a lot of different patients and a lot of different types of stents, but if you look at shorter courses, 3 to 6 months, versus longer courses, 12 to 24 months or more, what you see is mortality favors the shorter durations of dual antiplatelet therapy. And the reason is that when you go down and look at it, that there are more bleeding-related deaths related to DAPT that do not seem to be offset by a protective benefits of DAPT for thrombosis or other events. And so this data really then has led us to question, is shorter DAPT a preferred strategy for many of our patients? And that really has led to 3 of the big trials that I want to talk about now that have been published in the last year. So the TWILIGHT trial came, I think it made a big splash this year. It was a very large trial, 9,000 patients, and they were all undergoing PCI. They got randomized to 3 months, so they understood that the real risk period was that first 3 months, and they got randomized to DAPT at coming off at 3 months versus staying on for a year. This was a population of stable ischemic heart disease and non-STE-ACS. And interestingly, they did a unique thing. Instead of all those other trials I just showed you, their DAPT was when they stopped DAPT, they stopped the P2Y12 inhibitor and continued aspirin. In this trial, and in the ones I'm going to show you, what they do is different. They drop the aspirin and continue the P2Y12 inhibitor. So at 3 months, everybody's treated the same. Then one group stays on DAPT, one group just stays on a P2Y12 inhibitor, and they're followed. And you can see that when you look at bleeding and you drop the aspirin after 3 months, there's less bleeding complications without aspirin. And what's interesting is when you look at the MACE, there's no higher MACE without the aspirin. So it seems to be that there's a protective effect in that first 3 months, and then after that, that aspirin has more harm than benefit in this population. Around the same time, the SMART Choice trial has been done and presented and published, and is about a third of the trial, third the size, 3,000 patients, also undergoing PCI, randomized to 3 months versus 12 months of dual antiplatelet therapy. And again, what they did at the 3-month mark in half the population, they dropped the aspirin, and they continued the DAPT in the other group, and they continued patients on the P2Y12 inhibitor. This was about 3/4 Clopidogrel, 1/4 Prasugrel, Ticagrelor. There was a lot of ACS, so they didn't exclude STEMI. This was a real all-comers trial. And again, when you look at bleeding, there was less bleeding if you dropped aspirin at 3 months, and this was not offset by higher thrombotic events. Again, so less bleeding, but no price, at least in this trial. Now, even more interesting is the STOP DAPT-2. This is a real, I guess, aggressive regimen, depending on how you look at things. This was another pretty large trial, 3,000 patients, so about the same size as this other trial, undergoing PCI. And this group, which was, I think, out of Japan, randomized the patients at 1 month. So they realized that that 1 month was at real high risk, but then after 1 month, stopping the antiplatelet and continuing, and then the other group staying up till 12 months. And so again, at 1 month, half the population came off and stopped the aspirin, and this population, about 60% Clopidogrel, 40% Prasugrel, 40% of this population was ACS, there was STEMI, there was all comers in this. And again, once you drop the aspirin after a month, there was less bleeding, and there was no, interesting, even at a month of getting rid of DAPT, or getting rid of aspirin, there was no price to be paid in terms of MACE. Now, I will say that these outcomes in this trial are almost unbelievable. They were all IVUS-guided outcomes, and the event rates were very low, and this is probably a lower risk population. So I think this is intriguing, but is in no means definitive, but very interesting that this kind of fits with all the other data that we're seeing. So now if you take the randomized data from these shorter courses, we've got now almost 30,000 randomized patients to dropping aspirin at 1 to 3 months after a PCI and just continuing patients on P2Y12 inhibitors. And what you see is in total with these meta-analyses, you're getting better bleeding complications without, less bleeding complications without aspirin. And when you look at MACE, there doesn't seem to be a major price to be paid with regards to stent thrombosis, which is the main reason we're giving DAPT, or really MACE. And interesting, mortality, again, favoring and trending in the direction of lesser courses of dual antiplatelet therapy. Certainly not statistically significant, but another trend kind of favoring these, less, if we can prevent less bleeding, that we may be benefiting our patients more than preventing myocardial infarctions. And so, you know, this is really interesting data. This is really kind of showing that a lot of patients probably need less DAPT, but is this that everybody needs 3 months and that's it? Or have we really answered the question in all of our STEMI patients, in all of our complex CTOs and the other PCIs that we do, all the patients who have elevated risk scores and recurrent events? And I think the answer is we haven't answered this question, and we know that DAPT should be individualized. But the question is, are there ways, are there tools that we can use to better individualize our patients? Is it just use our gut, how we see the patient, or are there tools that we can use? One of the tools that's come up is the PRECISE-DAPT score. There's an app for it I've got on my phone. It's very easy to use. You can download it. And it was derived to sort of look at patients who get the question of who should get real short courses, 3 to 6 months, versus longer courses of 12 to 24 months. And it's 5 simple things: hemoglobin, white count, age, creatinine clearance, and if they've had prior bleeding. It gives you a score, you add up the points, and if you're over 25, that's considered a high bleeding risk. And so you put the things in the computer, it gives you a number, it tells you if that number's high, and then it also gives you what their risks for bleeding are. And this is the data from which it was derived. So it was derived from 8 randomized trials of 15,000 patients getting dual antiplatelet therapy, randomized to short versus long courses. And this looks at ischemic, bleeding, and net effect. And what I'd like to focus on is this net effect. So this blue line, if you focus on the blue line, this is the ischemic benefit minus the bleeding risk for any individual patient. And if you're above this line, patients are benefiting. And if you're below this line, then patients are being harmed by the therapy. And what you can see is that based on the PRECISE-DAPT scores, if you're not high, well, you might not be benefiting a lot, but you're certainly not being harmed much. It's kind of dancing around the neutral line. But once you go to high risk, there seems to be clear net harm in giving dual antiplatelet therapy that's longer compared to shorter. Now, what about if you look at this data in just these acute coronary syndrome patients? So the patients that guidelines would say we should give a year of dual antiplatelet therapy to acute coronary syndromes. Well, if you look at this net effect in blue, the benefit's a little bit more, and it seems to be at least on the positive side. So there's probably a slight benefit to going to a year of dual antiplatelet therapy if you're not high bleeding risk and you've had an ACS event. But if you're high, and even if the guidelines recommend a year of dual antiplatelet therapy, you're probably harmed by this therapy if your PRECISE-DAPT score is elevated. What about if you do a really complicated procedure? We do a lot of those here at Emory. Put in 3 stents, do some sort of bifurcation PCI. You put in a lot of stents, you do a CTO. Shouldn't you give those patients more DAPT? And the answer is, this is a busy slide, but I want to focus on the complex PCI group here and look at NACE. So again, NACE is this benefit minus risk. Are patients harmed, or are they benefiting by the dual antiplatelet therapy? And if they're not high bleeding risk, then it seems quite reasonable. They seem to be benefiting by longer courses. So you do a complex PCI, you give them a year or maybe even more of dual antiplatelet therapy, as long as they're not at high bleeding risk. But if they're at high bleeding risk, even if it's a complex PCI, they seem to be net harm favoring shorter courses, that there seems to be more bleeding in shorter courses, even if you do some sort of complex PCI procedure. So now the second question is, who should you refill? Let's assume, so that's the PRECISE-DAPT score. Just to summarize that, it helps you at the time of the PCI decide who are you going to just write for 3 months or 6 months and stop it. And that's something I think that we can do, is so you give 6 months and then you don't give refills. But then there's other patients who come back and they show up in your clinic and they've been on DAPT and they're doing okay. And the question is, should you refill the DAPT? And that's sort of a different question than how do you prescribe it from the get-go. And there's another app for that, and this is the DAPT score. This was derived from the DAPT trial, which randomized patients at a year who were doing well. And the DAPT calculator you can also get an app for it. It's endorsed by the ACC. And it looks at several presentation factors, and some of them are negative factors, some of them are positive factors, and you add them up and you get a score. Now, if you go back, remember we talked about the DAPT trial, and with the contemporary cohort that there was really no benefit. And remember we said there was no MACE benefit and there was only harm by treating everolimus-eluting stent patients, our contemporary stent population with dual antiplatelet therapy. And if you go back and look at this trial, then based on DAPT score, you can see there is probably harm if we give patients DAPT with low DAPT scores. So if we continue that DAPT compared to single antiplatelet therapy, there's no protection in terms of myocardial infarction or stent thrombosis, and there is increased bleeding, and there's increased mortality in that population who gets extended DAPT with low DAPT scores. Now, the opposite may be that these patients who have higher scores maybe do benefit. Maybe these are the patients who we should be refilling our Clopidogrel or our Aspirin in, at those that have higher DAPT scores. And you can see that compared to single antiplatelet therapy, those that get dual antiplatelet therapy, at least in this cohort, did have less MI and stent thrombosis. It did not, as a population level, have higher bleeding. Interestingly, though, that benefit without risk did not translate into improved mortality. I don't know, this may just be a play of chance. You would think that if you had a lot of patients over time having benefits without risk, you should see improved mortality. So this is probably just the play of chance, but it's interesting because the only reason I bring it up is that we're really lacking any data of people living longer with longer DAPT. I do think that there are patients that can live longer with longer DAPT, but we just don't have that data. The other thing to know about the DAPT scores, I don't want people to walk out and hear that this is like the greatest scoring system in the world and it's the best thing we should do for all our patients. There are a lot of controversies regarding this scoring system. This was just one study. I could present others that look at how it performs in the real world, and at least in this trial, they said it was a swing and a miss because it really had poor discrimination and calibration. So I don't want you to walk out and say that this is the end-all be-all, but it's at least something to give us some objective data about who benefits and who's at risk. For completion's sake, there are other risk scores. This is the Paris risk score that was derived from the Paris registry. It has two risks. It has one risk for major bleeding, another for thrombotic events. It's kind of like HAS-BLED and CHADS-VASc for our AFib. And I don't want to go into this is kind of a busy slide, but I think the takeaway is that what it shows you is that very few patients that we see have the potential to benefit. When you look at the absolute benefit of thrombosis and major bleeding, so clear benefit versus clear harm, you can see that most patients at thrombotic risk based on low, intermediate, high, and bleeding risk, low, intermediate, high. Most patients are either at low to intermediate thrombotic risk. They're either not benefiting or they're being harmed by longer dual antiplatelet therapy. And it's only a small percentage of our patients, it's probably close to 1 in 10 of our patients who actually derive a meaningful benefit. They're the highest thrombotic benefit. They're the highest thrombotic risk patients that are not at highest bleeding risk. That population is probably benefiting. We still haven't figured out how to define this, but I like this study that really, I like this graph because it really sort of says, 1 in 5 or 1 in 10 of our patients should be being left on these agents. The rest should probably be coming off indefinitely. So to summarize this, and then we're going to come back to this at the end, what do the guidelines say? Just for those who are about to take boards, the guidelines are 6 months for stable ischemic heart disease, 12 months for ACS. But I think this data really shows that most patients, or many patients, 3 to 6 months is sufficient. And interestingly, I think that what we're seeing is that maybe we should be stopping the aspirin, or at least this is what the newer data is saying, and continuing the P2Y12 inhibitor. And for those that are at highest risk, you need to interrupt for surgery 1 to 3 months. It may be very reasonable just to stop that at that time for surgery. I do think that DAPT should be individualized based on bleeding risk, thrombotic risk, PCI complexity, clinical presentation, and it should be remembered that really few of our patients should be being refilled. So that refill button should not be the norm, but the exception to the rule. And that probably what we should be doing in our PCI reports is calculating the PRECISE-DAPT and DAPT scores and giving this guidance to at least to help guide therapy, and remembering that it's really hard for anybody with a high PRECISE-DAPT score, no matter how complex the PCI or ACS presentation, for them to benefit. And these patients should probably still get just 3 to 6 months. And we should probably be hitting only that refill button for Clopidogrel and DAPT if their DAPT scores are elevated. This is a busy slide, but this kind of compiles it. This is a something I put together to put together the PRECISE-DAPT, the DAPT scores based on complexity of PCI and clinical presentation. We've posted this in our cath lab, and something to consider whether this is what we want to do. We can certainly modify this, but the concept is trying to be a little bit more prescriptive and not just having one size fits all. This 1 year of DAPT needs to probably not be a recommendation to patients, because it's just too one size fits all. It's not helping. So, and one other question is, really, should we ever use extended DAPT? Maybe 3 to 6 months is DAPT, and then everybody stops. And if we really want to continue dual therapy, then maybe the better dual therapy is low-dose Rivaroxaban. And what we mean by this is Rivaroxaban at not the 20 milligram dose, but 2.5 twice a day. That instead of doubling down and doing an antiplatelet and another antiplatelet, do antiplatelet and hit the thrombosis from a different mechanism of action. So that's the concept, at least. And there is data for this. The COMPASS trial, you've probably heard, and if you haven't heard, people are coming around and talking about this. There's a very large study of patients with coronary disease. Got randomized to, it was a 3-way randomization, but we're going to focus on antiplatelet alone versus antiplatelet with low-dose Rivaroxaban. And when you looked at the benefit of adding low-dose Rivaroxaban, there was a benefit. Again, this number needed to treat was quite modest, but it was there, and it was the statistically significant benefit. But the trial was stopped early because of this benefit. But what was really interesting is what drove the benefit, and there was actually a statistically significant reduction in mortality in COMPASS trial. This is a signal that we're really not seeing in the DAPT literature, and also a reduction in stroke, but no statistical reduction in non-fatal MI. Now, how to put all that together, I'm not quite sure, and maybe we can discuss that at the end. But there is a downside to giving 2 agents. Anytime you give people 2 things that make you bleed and compare it to 1 thing that makes you bleed, you get more bleeding with the 2 things. And that's certainly the case when you look at all of our bleeding definitions here. So more bleeding with Rivaroxaban. Now, this is very intriguing data, but what it doesn't do is it doesn't answer our question, which is really, should I give the patient extended DAPT, or should I change him to dual therapy with aspirin and low-dose Rivaroxaban? So that's the real head-to-head that we want. And there has been one small trial to look at that. It was a small 3,000 patients randomized with ACS, and they randomized to dual antiplatelet therapy versus single antiplatelet therapy and low-dose Rivaroxaban. And so the antiplatelet was actually everybody continued P2Y12 inhibitor. So both groups got the P2Y12 inhibitor. One group got aspirin, the other group low-dose Rivaroxaban. So when you look at this randomization, 2 versus 2, there was no benefit in MACE, and there was no benefit in bleeding. So, what do we do with this data? I guess the optimist would say, well, it's no worse than dual antiplatelet therapy. It's no worse in terms of bleeding, and it may save some lives, so maybe it's a good thing to do. The pessimist, which is probably me, would say there's no signal that this is really any better than DAPT, and Rivaroxaban is certainly expensive and twice a day. So I think we need more data. So should we use this today? We're certainly going to hear a lot about this, but I would say I don't know, and we can talk about this at the end. It's very intriguing. I want it to be true. I'm not sure that I think it is true. So switching gears, and I want to make sure we have enough time to discuss things, because I think that the discussion will really be fun. What is the optimal antiplatelet regimen when anticoagulation is warranted? So we certainly know that a lot of patients need anticoagulation. We do a PCI, and so what do we do with antiplatelets? I think that this is becoming less of a question. We now have several randomized trials. This is a meta-analysis of over 10,000 from 5 randomized trials. We know these names. We've looked at them: AGUSTUS, PIONEER, WOST, ISAR triple. And what they say is that triple therapy, this is DAPT plus anticoagulation versus getting rid of the aspirin and doing P2Y12 and anticoagulation. You can see that when you drop the aspirin and get rid of the aspirin, there is no price to be paid in terms of stroke and MI, and there is less bleeding. So certainly I think that this is now sort of the standard of care is dual therapy and getting rid of the aspirin, continuing with P2Y12 inhibitor. Now, there was a question, what was the best anticoagulation after PCI? Do we give warfarin? Do we use the NOACs? And I think that now we have data that really suggests, like all the other parts of cardiology, that the NOACs are preferred. In the AGUSTUS trial, they randomized patients to vitamin K antagonists versus apixaban, and there was less bleeding with apixaban. So I think the data is now drop the aspirin and use NOACs, or NOACs, however we want to call these now, for most of our patients. And I don't think that that's controversial, and I think that's pretty common. Where I think that there's a little bit of new data that's worth talking about is, remember, we started with this slide. So this is the slide of where stent thrombosis occurs, and this big risk of stent thrombosis. So stent thrombosis, when you put a stent in, is really clustered in this first 30 days, maybe out to 90 days, but certainly in this first 30 days is the big vulnerable. So did this data that we just showed answer the question of what to do in this first 30 days? So now that we're getting meta-analyses and looking at stent thrombosis, with dropping the aspirin, we're seeing that when we get rid of that aspirin, and that there is more stent thrombosis. Now, it's a relative 67% increase on an absolute. Remember, these numbers, especially in our elective populations, are quite modest. So the absolute's very low, but the relative benefit is quite concerning. And when you look at the AGUSTUS trial at stent thrombosis, you can see where the vulnerable period was. That when you got rid of the aspirin, early on there was more stent thrombosis, and 80% of the stent thrombosis that occurred in AGUSTUS, that was higher than the 80% of the stent thrombosis that occurred, it occurred within the first 30 days. So it does suggest that this first 30 days is not like the other days after 30 days, that there's this vulnerable period, and that when you get rid of the aspirin, there is more stent thrombosis. So what do we do with this data, and what is our optimal antiplatelet regimen with anticoagulation? It does tell us that maybe triple therapy for those first 4 weeks is still very reasonable for patients at highest risk for stent thrombosis, our ACS patients, our complex PCIs, other patients like that. So it is very reasonable to try to reduce that stent thrombosis that occurs in the first 30 days. But after 30 days, that risk really drops off, and we should get rid of the aspirin. We go to dual therapy with a P2Y12 inhibitor and anticoagulation. The NOACs or the DOACs are now our preferred over warfarin for most patients. And when we're using 2 therapies and certainly 3 therapies, we should consider routine PPIs during that time. Now, one of the other interesting things that's come up, I think, in the last year that really we haven't talked about is, okay, you've done your PCI, you drop the aspirin, you're on the P2Y12 inhibitor, you're on the anticoagulation, you come back to clinic at a year, and now what? Do you refill everything? They have coronary disease, they need antiplatelet therapy. They have an indication for anticoagulation, atrial fibrillation. What do? Do you refill both medications? Do you change back to aspirin? And what we're seeing is that there's probably a trend again towards getting rid of the antiplatelet therapy. This is registry data, so it's got its biases, but they looked at patients who needed anticoagulation, had coronary disease, and had not had a recent PCI. They looked at patients who got 2 things, warfarin and aspirin, versus warfarin alone. And after adjustments, they had much higher bleeding and hospitalizations in those who had 2 versus just coming off the antiplatelet and being on anticoagulation. And there was no benefit in terms of thrombotic protection based on having 2 of these agents together. Now, this is non-randomized. So this group went out and set out to do a randomized trial and try to answer this question. So they took almost 700 patients. They all had atrial fibrillation. They got PCI. And if they were doing okay at that 1-year mark, they got randomized to that do you refill or not refill question. They either stayed on oral anticoagulation or oral anticoagulation or oral anticoagulation with antiplatelet. You can see that continuing that antiplatelet benefit really was of no benefit. It was also of no harm, and it was because they really couldn't randomize. They had to stop this trial for futility. And what was really interesting, I think, is the discussion, because they said the difficulty in patient enrollment mainly stemmed from the substantial reluctance of cardiologists to withdraw antiplatelet therapy in stented patients. And that really does sort of, I think, summarize where we've been. It's very hard for us to think about stopping aspirin in patients who have had a PCI or stent. And so they were not able to finish this trial. Fortunately, another trial was recently done and published. They took, it was a modest size, 2,236 patients with atrial fibrillation. They had PCI. They got randomized at that 1-year mark to just continuing that anticoagulation or continuing antiplatelet and anticoagulation. And if you dropped the antiplatelet, now this was a pretty contemporary trial, contemporary stents, contemporary anticoagulation regimens like Rivaroxaban, and if you got rid of the aspirin, the antiplatelets, there was a benefit compared to dual therapy, and this was really driven by the primary safety efficacy of less bleeding. So it seemed to be just as good and less bleeding if we got rid of the antiplatelet in most of our anticoagulated patients. And remember, this patient population is largely atrial fibrillation. Our atrial fibrillation patients are largely older than the other parts of our PCI population, and that may be part of why this is, that as you get older, there's more bleeding risk than ischemic protection. There are guidelines. The Europeans have said discontinuation of antiplatelet therapy in patients with oral anticoagulation should be considered at 12 months. It's a 2A indication, not a class 1, but some strongly consider getting rid of the antiplatelet. So what do you do after that 12-month mark? You've had your PCI. Do you refill the antiplatelet? And I think the answer is for most patients, not all, but drop antiplatelet agents in most patients. Now, last question, and then we'll stop for discussion. I know this is kind of a whirlwind, and I apologize, but I wanted to try to get through all this because they're all sort of intertwined. All these different questions are a little bit interrelated. So the last question is, which patients should get Prasugrel or Ticagrelor? So going back to the pivotal trials that led to these agents, I'm sure we all remember Prasugrel was studied in Triton-TIMI 38, very large study, high-risk ACS. This was all PCI. And Prasugrel reduced events compared to Clopidogrel. Now, this is the thing to pay attention to. This absolute benefit was about 2% absolute reduction, and there was more bleeding, and the bleeding was about a 0.6% increased risk. 2% benefit, 0.6% risk. Then Plato was done looking at Ticagrelor. Again, large study, ACS, randomized Clopidogrel versus Ticagrelor. When you look at MACE, was a benefit, and again, that benefit was about a 2% absolute benefit. Now, what we got sold on was that there was no more bleeding because they used a different bleeding definition, so we were told there was benefit without risk. But when you went back and in the initial publication and used the same bleeding definition, not only was there more bleeding with Ticagrelor, but there was actually numerically the same, so 0.6% increased bleeding. Both agents in the pivotal trials had 2% benefits, 0.6% risks of increased bleeding. So very similar data, but with this data, Ticagrelor really became the market leader. And so which is better, Ticagrelor or Prasugrel? They seem similar. And now we do have head-to-head. So this is one study, 1,230 patients randomized with STEMI. The only randomization, they just got Ticagrelor, they got Prasugrel. They stopped the study early because they got to futility. Death, bleeding, and myocardial infarction were the exact same with all three agents. So there was the exact same. There was no bleeding protection, which we saw in Plato. It was exactly the same. Now, more interestingly is the ISAR REACT 5 trial, which really made, I think, a splash recently. And it was 4,000 patients, so a good-sized trial. ACS, it was STEMI, non-STE-ACS, randomized Prasugrel versus Ticagrelor. And I want to say that this is not only a randomization of the two drugs, but it's also a randomization of how the drugs are given in practice. Prasugrel is given in practice in the cath lab. It's not given upstream. You wait till you get to the cath lab, you define the anatomy, you give Prasugrel. There's no preloading. Ticagrelor is given as it was done in Plato, which is at diagnosis, upstream before the cath, and then along and then downside. So this is really a two-way randomization, one of drug and one of delivery. And so there was two reasons to think Ticagrelor may be better. And when you looked at bleeding, Ticagrelor was no better, in fact, trending in the opposite direction, but at least very similar. So same bleeding in several trials now, that Ticagrelor makes you bleed just as much as Prasugrel. I don't think there's any question about that. But interestingly, then when you looked at the MACE benefit, it actually favored Prasugrel. And this was sort of a double negative. It was a negative against Ticagrelor. It was also a negative against preloading, because these patients got preloaded and they did not benefit in terms of MACE. Now, we can talk a little bit about why this is, and there's probably a lot of reasons, and we also probably don't know the reasons to some of this. But one of the things comes up is that Ticagrelor does have a compliance issue. It's twice a day, and it does make you have more shortness of breath. So almost 1 in 5 patients, at least in PEGASUS, had dyspnea with Ticagrelor. So we are seeing lower compliance, more side effects in terms of shortness of breath, perhaps leading to discontinuation early. That may explain at least some of that. It probably doesn't explain all of it. But regardless, I think when you look at it, say, which is our better drug today, Prasugrel or Ticagrelor, I would argue it's Prasugrel. Prasugrel is once a day. Ticagrelor is twice a day. Prasugrel doesn't make you short of breath. Ticagrelor does. Prasugrel is at least as safe as Ticagrelor. There's no bleeding advantage to Ticagrelor. And maybe, just maybe, I'm not going to say definitely, but maybe there's a better efficacy. So now, is that our agent? Now do we just go to everybody gets Prasugrel, or do we still use Clopidogrel? Is there still a role? And remember, just to finish here, Clopidogrel is a prodrug. It does require metabolic activation. And we know that patients who are carriers of the CEP2C19 reduced function allele aren't able to metabolize Clopidogrel. And Clopidogrel, this gene accounts for about a quarter, maybe a third of our population. What's interestingly then, if we go all the way back to the Triton trial and looked at how Prasugrel compares against Clopidogrel in randomized patients, and then go back and break down this data based on their Clopidogrel responsiveness, what you see is that if you're a Clopidogrel responder, if you've got the genes, if you can metabolize, if Clopidogrel gets broken down, and you compare it to Prasugrel, the hazard ratio is essentially 1. There is no benefit at all to Prasugrel over Clopidogrel when Clopidogrel works. But when Clopidogrel doesn't work as well and you compare it to Prasugrel, Prasugrel looks really, really good. And now the number needed to treat is not 50, but 16, with probably a mortality advantage. So again, this benefit of Prasugrel is really driven by response. And now we have some randomized data. This was published in the New England this year, of patients with STEMI. This is almost 2,500 patients. They got randomized to give everybody Ticagrelor or Prasugrel, so sort of a universal, just give everybody the newer agent strategy, or we genotype them and give them Clopidogrel unless they're genotyped it doesn't favor it. And you can see that it was a non-inferiority trial. When you look at this NACE benefit, that the genotype guided strategy was non-inferior. In fact, trending towards better, but certainly we can't say anything. This was a non-inferiority trial. But when you look at bleeding, which a lot of this was minor bleeding, there was actually less minor bleeding with the genotype guided strategy. Now, when you look at major bleeding and real hard outcomes, they were pretty similar, but maybe less nuisance bleeding when we genotype patients and give them Clopidogrel. And there was one other randomized trial, instead of looking at genotype, but looking at platelet function guided, again, about the same size, ACS, randomized, everybody gets Prasugrel, so universal Prasugrel, versus phenotyping with platelet function testing, and then giving those Clopidogrel if the platelet function test suggests that Clopidogrel responder. And again, it's a non-inferiority trial. Using platelet function testing is non-inferior and may even be slightly better, again, driven by less nuisance bleeding. So how do you put this together? And then we can stop for discussion. I think today Prasugrel is preferred over Ticagrelor. I think it's important to remember that we should use the lower dose when age is over 75 and weights are low. And I think Clopidogrel, guided by genetic testing or platelet function testing, we can talk about which is better in a minute, provides similar outcomes to Prasugrel at reduced cost and maybe reduced minor bleeding complications, which is a nuisance to our patients, and still may be a great therapy for a lot of our ACS populations, at least 3/4. And I think Ticagrelor, I would reserve it for non-responders to Clopidogrel who have a history of TIA or stroke, because that's a absolute contraindication to Prasugrel. So this is my last slide to just put the whole talk together, and then we can open it up for discussion. So one of the themes is dropping the aspirin. Many patients, after 3 to 6 months after PCI, probably getting rid of aspirin today and staying on a P2Y12 inhibitor. And when you do a PCI and the patient needs anticoagulation, I would use triple therapy for a month, but at the 1 month mark, get rid of the aspirin again and let them go on just a P2Y12 inhibitor and anticoagulation. And when they come back at the 1 year mark, most of these patients should probably come off all antiplatelet therapy. Not all, but most, and just stay on anticoagulation because there seems to be more bleeding. I think it's important for us to remember that really few of our patients, it's 1 in 10, maybe a little more, benefit from long-term dual antiplatelet therapy. So we should be aiming to reduce, not aiming to continue our DAPT. And I think what we should do in our cath notes and our PCI notes is to calculate these things, the PRECISE-DAPT score, the DAPT score. We may get some better risk scores. I don't want anyone to walk away and say these are the perfect scores that perfectly tell everything. No, but they give us a guidance. They put us in the right direction of longer, shorter, who has a potential to benefit. And so maybe we should put these in our notes and guide this a little bit. And before you hit refill, think about calculating that DAPT score before the Clopidogrel gets refilled. And I think Clopidogrel is still a great drug for responders. It seems to be just as good. It's cost effective. It has less nuisance bleeding, but it only works if you test it. So if you don't test it, you're very at risk to send out patients who don't work in ACS, and Prasugrel would be preferred. I think Prasugrel is our now preferred agent in non-responders, and it is moving generic. It technically is generic, and we can talk about it, but someday it may be just as cheap as Clopidogrel and easy to get, and we may think of it as our agent of choice, but it isn't today. And just the final thought is, and I didn't show any data on this, is there may be a renewed interest in genetic and platelet function testing now that we're going and dropping aspirin. So the question is, if you had to pick one if you got a stent to your mid-LAD and you were going to be on one antiplatelet agent, what antiplatelet agent would it be? Long term. Would it be aspirin? Would it be Prasugrel? Would it be Clopidogrel? And if it were Clopidogrel, would you want to know if you were in the responder group or the non-responder group? So with that, thank you. Sorry, a whirlwind, I know. Too much data.
Mike, what's your response to somebody that comes in and says, we want to use Prasugrel initially for 1 month, and then we change the Clopidogrel?
I think it's a great idea. What I would say is that I still think, I'm sorry, yeah, the question is, should we think about using Prasugrel? And I'll tell you, my inclination is that we should do a couple things. This would be my recommendation. We should bring in genetic testing and use Spartan testing. And we should stop preloading most of our patients, and we should get them to the cath lab and make the decision based on angiography. In the cath lab, we should give everybody Prasugrel. We should load with Prasugrel. We should probably even crush it and get it in faster, which has a little bit of benefit, but at least we're getting it in orally. Then we should test everybody and test to see if they're a Clopidogrel responder. And at that point, you can decide what to do. You could continue Prasugrel, but you know that they're a responder. And so when they show back up in your clinic, you can make a decision. They say, I can't afford this Prasugrel anymore. I just, what to do. You can make a decision. You could, but you'll have this information. Because what I'm worried is that we're moving towards getting rid of not the Prasugrel, but the aspirin and continuing DAPT. And so the question is if, let's say you were a Clopidogrel non-responder, and you came in and at the 1 month you changed from Prasugrel to Clopidogrel. Well, first you have to load them with Clopidogrel. Secondly, then you continue them for 2 months or 6 months, and then you drop the aspirin. Well, now you've left the patient on one agent, and you don't know if the Clopidogrel works. And if you've tested it, you're giving them Clopidogrel that doesn't work as well. So I think what I'm trying to say is I think having this information at the time of discharge, that we should get Spartan genetic testing in. We should test everyone. Just because you're a responder, I'm not saying you have to flip everybody back to you could say, I'm a clopidogrel responder and I'm going to send you home on Prasugrel, and that's reasonable. But you go home with the information about the individual that you have about how clopidogrel works, so that then you could make a determination at 3 months, 6 months, 1 year, what antiplatelet to do. So I like the strategy, and I actually think we should be giving everybody Prasugrel. We can only give everybody Prasugrel if we use genetic testing. The reason we can only do that is that so if you can only test clopidogrel if you give clopidogrel. So the reason we load and use clopidogrel right now is because we test it with platelet function testing. So we actually give it and then see if it works, and then we stop and go back, and then we reverse. If you went the other way and if you use Spartan testing, genetic testing, you don't have to give clopidogrel to test it. You can test everybody. So you could give everybody Prasugrel, and then you could test to see if they're a clopidogrel responder, and then make decisions. If your patient doesn't have insurance, doesn't have this, whatever, you can make decisions. You could do a month of Prasugrel and then go to clopidogrel, or you may make a different decision if they're a clopidogrel non-responder. Dr. King?
Michael, I know you know this is coming up, but because we've talked about it so many times, it seems like if you're going to change practice, and your point is that we use too much antiplatelet therapy chronically, and we're causing a lot of bleeding, which is sort of the trend that you've emphasized. And the reason is that physicians are unwilling to take the dual antiplatelet therapy away. It occurs to me that if you're treating the patient and you're giving them drugs and they have a problem, namely bleeding, the doctor's done his best. But if you don't give the drug and they have a thrombotic event, you screwed up. And so it seems like to get this message through, we need some, and also the guidelines aren't backing you up.
Yeah.
But to get to where you're talking about, will somebody ever do a study, for instance, using Prasugrel for a month or 6 weeks or something like that in everybody, since all your thrombotic events are in that zone, and then nothing? And see, you'll obviously decrease your bleeding, and will you increase or identify the patients who need chronic therapy? Because the best antithrombotic for stent thrombosis is a well-placed stent that good technique, and you don't have. So, but if you did a study like that, a very short duration versus nothing, long term, in the broad population, I don't know who would pay for it, not the Prasugrel company.
I think your point is very well taken. I mean, I think that is the trend I see, is that we probably just need less. But there are patients who more is more. And I guess the one takeaway, I would say one takeaway for this message is that doing less antiplatelet is definitely the theme across the boards. And maybe some of that less antiplatelet is the aspirin. But then the other theme, I think, is can we individualize these decisions a little bit better? And if we had risk scores for our patients, and we just put the PRECISE-DAPT score and the DAPT score, and you knew if they were a clopidogrel responder, that combination of things could become a better cocktail for individualizing the patient in front. To say that everybody needs short 3 months or even 6 weeks, I think maybe too oversimplification. To say everybody needs a year of DAPT, as the guidelines would say, is also an oversimplification. So I think trying to individualize these with some markers of risk is my suggestion of where to go in the short term. But I would love to have more trials. I think that the less we do, I think we're moving in a less direction. We may only need 6 weeks or something for most patients.
Mike, after sort of you're finished with the dual antiplatelet period for these patients, and you go back to sort of long-term aspirin, and I'm not talking about folks on anticoagulation, just standard chronic management of coronary disease. Do you think low-dose aspirin is the best long-term? I know, this is sort of just your opinion. There's probably, versus should there be people that are on clopidogrel or nothing at all, et cetera, long-term.
Yeah, in getting ready for this talk, I went back to pull like the old Capri data, and these are like, can you even like make sense of a lot of this stuff? And the answer I just think is we just don't know. But I do think that clopidogrel is slightly better than aspirin. And now, is it slightly higher risk of bleeding? I'm just not sure looking at this data. It's really not clear. The other part to thinking about every clopidogrel trial that's ever been done is actually a randomization of two populations. It's a population of three quarters that it works in and a quarter that it doesn't work in. To me, it's like comparing aspirin to Prasugrel, 3/4 getting Prasugrel and 1/4 getting, I don't know, Letol or something like that. Some sort of lesser, and then trying to come up with a total of that population. They're just two groups. I guess what I would say is that I would like to know if I was a clopidogrel responder. And if I was a clopidogrel responder, it's generic, cheap, easy to use, we're comfortable with it, and I probably would use clopidogrel as my antiplatelet of choice. But I would want to know if I was a responder to it. And if I weren't, then the two options are aspirin or Prasugrel. And I guess you could make an option based on if I was a really young, non-bleeding risk person, maybe I'd do Prasugrel, and for the rest of patients, I'd probably just do aspirin. But that's just there's no data for that. That's why.
If the Prasugrel is generic, would that change your answer?
Well, I think it would certainly help, but there's less nuisance bleeding. So when you say, wait, what's Prasugrel? So Prasugrel compared to clopidogrel versus clopidogrel guided by platelet function testing. And I didn't show this slide, but there's a thought that just like Coumadin and an INR, there's a therapeutic window, and when you go above, bleeding, and then more this way, there's more thrombotic risk. And when they went back and looked at platelet function testing on clopidogrel, there's this idea that there's a therapeutic window of platelet function testing that PRUs between 95 and 200 or so is this therapeutic window. And that's the benefit. And what I would say is that if you gave everybody Prasugrel, you would have more people outside the therapeutic window compared to clopidogrel guided by platelet function testing or genetic testing. So to say which would I use, it is partly an economics, but I think that there may be less nuisance bleeding and just as much benefit, maybe hitting that sweet spot with clopidogrel over Prasugrel in all comers.
So non-responders to clopidogrel, if we don't know about it, or if we know about it, what are the chances they'll have stent thrombosis in the first month or so? Do we know that?
If
they're non-responders.
their stent thrombosis risk is higher, yeah.
How much higher? You know that?
It's about a 3, in the ADAPT DES, it was about a 3-fold increased risk.
Yeah. It's not tremendous, but.
Well, the risk of stent thrombosis in general is so low that when you talk about absolute, you could double or triple 0.2%, and it's only going to be 0.4 or 0.6%. So.
What's the turnaround time on that test?
On what's that? Which one? The P2I? The platelet function testing is immediate. It's so you send it down to the lab. It's actually a point of care
it's like
test.
one day, but it's.
No, if you send it down, it comes back like it's you're limited by how long it takes to get to the machine. It's actually designed as a point of care. In fact, a lot of labs have it in their cath lab and run it in the cath lab, and you could have it back like an ACT if you wanted to. Spartan genetic testing, which I think we as an Emory system should bring in, it's also a point of care test. It's a buccal swab for genetic testing, and you can get the answer back in an hour. So theoretically, you could have your answer, back while they're still after the STEMI. They're still anticoagulated in the CCU. So
Prasugrel is an issue in a lot of our patients who are given Prasugrel. They're sent home with a prescription. They get to the pharmacy at the 1 month mark, and the price is like unaffordable.
yeah.
So it always bothers me a little bit to talk about bleeding, because bleeding reminds me of bleeding with the aspirin and no aspirin situation. Either you bleed 7 units of blood or you have hemorrhoidal bleeding or whatever. And I know you had it classified one time there, but it bothers me just to say the complication is bleeding, but that's about the way it goes nowadays anyway.
It's hard. It's also, I think it's hard, we've chased, the flip side is we've chased an MI definition that's also kind of hard and nebulous. And so, you know, a lot of our benefits that we've seen over time in terms of MI reduction are these chemical MIs, these troponemias that we've stopped, and we all know that they're meaningless. And so, you know, I think some of the reductions that we've seen in some of the ways that drugs get sold is reductions in chemical MIs that really are absolutely of no value. So it goes, I think, both ways too. Yeah.
Great talk.
Oh, well, thank you. All right, thank you.
The preceding program is copyrighted by Emory University.